Welcome back to the Life After Impact podcast. This is part 2 of my conversation with Dr. John McClaren, an expert in traumatic brain injuries, concussion recovery, and autonomic nervous system dysfunction, practicing near Omaha, Nebraska. In this episode, after geeking out about jump ropes, we continue to explore his functional neurology approach to treating autonomic dysfunction and concussions. We discuss the use of pulsed electromagnetic frequency devices to improve vasomotor activity, and the use of hyperbaric oxygen therapy, where he takes it one step further and shares how specific examination findings, such as the pupillary light reflex and a 5-minute sustained hand grip test, further help him to differentiate who truly is a good candidate for hyperbaric oxygen therapy. We discuss heat intolerance as a manifestation of autonomic dysfunction due to a loss of normal sweat response, the use of compression gear, and the importance of therapist-guided gradual return to activity and exercise as it's appropriate for the individual. And we touch upon head-eye vestibular motion, a functional therapy that utilizes eye movements, head movements, and vestibular activation as part of neurorehabilitation. And then we touch upon long COVID as a possible setback in people's recovery due to inflammatory consequences and further insult to the autonomic nervous system. Thank you so much for listening to the podcast. If you have topics you would like us to explore, please text us using the link in the show notes or send us an email at lifeafterimpact@gmail.com.
Welcome to the Life After Impact podcast, where we do a deep dive into all things concussion and brain injury related. We talk about all the different symptoms that can follow a brain injury, different testing methods, different types of specialists out there, and different therapies available. I'm Sophia Bowens, and I'm here with Dr. Ayla Wolf, and we will be your guides to living your best life after impact.
Yeah, I had just a major geek moment the other day. I was listening to a podcast. It was a CrossFit podcast, and they were interviewing a guy who teaches like jump rope classes. And all of a sudden, he launched into what, from my perspective, was like a functional neurology explanation of why jump roping is so important to toning the autonomic nervous system. Yeah. And talking about how some people are more upper body dominant and other people are lower body dominant. But when you jump rope, you've got to sync up your timing of your wrists with the timing of your feet and your jump. And so, basically he just like launched into this whole neurological, reasoning for why jumping rope was this way of like creating better neuroplasticity in terms of like how the coordination between your upper body and your lower body. And of course, in my mind, I'm like, and then we have the inferior olive, which is all about timing. And that goes into the cerebellum and
put the metronome to the jump rope and see what happens, right?
Yeah, metronome and a jump rope. Like that could be a magical therapy right there.
We might have just, call it the Wolf McLaren jump rope protocol.
Let's work on that.
Yeah, but you throw in the vestibular aspects as well, right? I mean, it's like this big thing. And not to mention the proprioceptive bombardment from lumbosacral spine, which is one of the reasons I don't jump rope as much as I probably should. That I suck at it. It's like, I know it's a great activity. And that's the cool thing about CrossFit, or any of these athletic endeavors. It's motion at a higher level. We look at gait all the time, but you go, okay, the gait's okay. How do I jump rope? How do I jump rope with a dual task or something like that? That could be a really, really nice high-end way to test. And I know, one of the things you had mentioned in the questions leading into today was what can people do at home, and these are things you can integrate your activities of daily living in to how to rehabilitate yourself as well.
Yeah, and I think that you mentioned you've got a PEMF device, and so do I. And one of the things that I really have spent a lot of time researching and wrote about in my book was the importance of vasomotion within the cardiovascular system and the arteries, and even within the brain too. And so I think that one of the things that the PEMF devices are so helpful for is restoring that healthy vasomotion. And especially when you've got somebody who maybe has dysautonomia and exercise intolerance and can't necessarily move their body at the high level that they maybe were used to, something like that can really come in and support that system in that way too.
Absolutely. It's so interesting. And a lot of people, they like hyperbaric oxygen therapy for these kind of things as well, because again, you're increasing blood oxygen concentration. The pulsed EMF, vasomotion, remodeling, kind of in that neuronal pool because of that, and so on. Yeah, you want to heal white matter. I mean, those are two of the best modalities that you could potentially use for sure. And of course, just like anything else, be judicious, right? Have a biomarker. Everybody says that. Well, what's the protocol? And I think you've probably found this with your PEMF too. There aren't necessarily standardized protocols, right?
Yeah. I mean, a lot of times it's like, let's just start you out really, really light and just very slowly bring you up and then, kind of cycle through. But yeah. And, some people like with mine, they'll lay on it at a level 1 and they'll say, oh, wow, I can just really feel like, all of this stuff happening in my body. Well, I have to have it on level 7 before I even feel anything. And so
it's interesting. Yeah. Yeah. You boost the field strength up and you can vary your field intensities and things like that. It's fascinating stuff. And that's the thing. I think there will be established research parameters for this stuff on top of everything else as we go. Same with hyperbaric. That's the thing. There are a lot of people, again, talking about, what's great for everybody. Nothing's great for everybody all the time, right? If it was, we'd all, if hyperbaric was the thing to do for dysautonomia with concussions, we'd have like 10 hyperbarics in our office and everybody'd be doing that all day long. I mean, and before I really, really understood the dynamics of, this, especially this sympathetic activation being important, I was putting a lot of people in hyperbaric and getting mixed results because sometimes it's too much of a stimulus for that parasympathetic system. You're really driving vagal systems. And they'd come out there like, oh, I feel great. And then, they'd have a hard time for a little while. And now when I understand it, do I have pupillometry that's appropriate for the stimulus? Do I have, one of these, we do this hand grip test, and see, do I have adequate activation of that sympathetic system to be able to handle the stimulus? You talk about sweating and one of the things, what's sweating's most important function? Dissemination of body heat, right? What's one of the things these people with dysautonomia tell you? I suck in the heat.
Yep.
I can't wait for fall. Yeah, because they can't disseminate heat properly because they don't have activation of the sympathetic system appropriate for it.
Yeah. And I think that's something that people also, kind of miss is the fact that it's not a teeter-totter. It's not that when parasympathetic activity is high, that sympathetic then is by default low. These are two completely separate arms of the nervous system doing their own things. And so there can be maybe a relative excess of sympathetic compared to parasympathetic, or you can have it where there is actual decreased parasympathetic and increased sympathetic. And so we do have to look at it not as a teeter-totter, but as two separate output systems that can be independently doing their own thing, but we need both of them to be appropriately responsive.
Yeah, it's just like when you test balance. It's context-specific weighting, right? I want my brain to be able to stand on a perturbed surface with eyes closed. Then I want to be able to do things with eyes open. Then I want to be able to do things on a normal surface. And the brain will reweight the systems according to the context and the demands of that context. It's the same thing with the autonomics. Again, I need to digest the steak, and then I need to fight off the intruder or whatever it is relatively quickly. And then once the intruder's fought off, I got to finish digesting the steak.
Yeah, go back to what I was doing.
Yeah. And then hopefully go to bed and do it again the next day. These kind of things. Yeah, it's exactly what it is. That's what the brain does when it works the way that it should, is it can take every system that it communicates with and it can weight it appropriate to the current demands, but the background processes work appropriately. And in order to do all that, you have to have fuel, oxygen, vasomotor activity, exactly all of those things. And when it comes down to it, everybody will ask, well, what is a symptom of autonomic nervous system dysfunction? anything they can come in with, because if I can't fuel my frontal lobe, I'm going to have executive dysfunction, right? If I can't fuel my vestibular system, I'm going to be dizzy or lightheaded or have some kind of translational issues or have background contamination throw me off or any of these kind of things. If I can't, if I can't fuel my cerebellum, I'm going to have maybe some of these like speech issues or some of these issues in cognition as well, or activity coordinations of motor activity won't be super well. You'll see miscoordination in like the way a hamstring contracts or things like that. Things that you're doing in your postural assessment. And again, blood and oxygen. Every neuron needs it. Blood, oxygen, and activation, right?
Yeah. And for everybody, that can look completely different in terms of how to get in there and start stimulating it. So you mentioned you've got your hyperbaric, you've got your PEMF. Do you also do like the Normatec compression gear, or like, are you doing compression, or what else are you kind of integrating?
I haven't used that. I haven't used that in my office. I will have people use compression wear. Even if it is just a simple compression stocking like you'd get if you're a runner. A lot of marathon runners wear compression wear because it's smart when you're doing, tons of miles. You're going to get some blood pooling and interstitial issues as things happen. But that kind of wear works really well for people who have autonomic nervous system dysfunction, particularly those like orthostatic phenotypes. Because the thing is, I can't get blood out of my legs back into my head with those types of guys, the POTS, those kind of things. So the compression wear is super helpful. But I'm not using that. I use some photobiomodulation in my office, the PEMF, the hyperbaric, and the rest of what I do is kind of this, some aspects of myofascial release that are neural exam guided and head-eye vestibular motion therapy aspects. I like Focus Builder. I'll have people use Focus Builder a lot. No disclosures there. I do some mentoring for them, but I'm not a stock owner. I wish I was. I just think it's one of the best programs for a functional neurologist to use in their practice and with their patients, because you can do all of these things with it, from metronome timing to pursuits to saccades to role applications when you've got role playing issues and all these kind of things. So I really, really like it. And I use that in my head-eye vestibular motion approach. I have a lot of people, they'll simple things, they take some fine motor activity home. They take a board that I made that's got some targets on it. And they'll do some saccades or some gaze holding or some pursuits in addition to what we do in the office. That's kind of where it is. It's kind of a nuts and bolts approach with some accoutrement for sure.
Yeah. Are you currently seeing a lot of people with, where maybe they had a concussion, then they got long COVID, and then they had all their concussion symptoms come back?
Yeah. I mean, you get any of these things. And that's, one of the things we talked about. Long COVID, definitely a contaminator, or, mold issues, Lyme, those kind of things, where maybe they've had a concussion and then this kind of thing comes on. Yeah, it looks like a second concussion for a lot of these people, or a third or a fourth or a fifth or things like that. And they're different animals because you're seeing, different aspects of activation in the inflammasome. You're seeing a skewing of the microglial axis and things like that. That is a little different because there's a pathogen or something like that comes in. But you see that stuff, the inflammasome activation, the changes in cerebral blood flow that happen with a TBI as well. So boom, second insult, sometimes it kind of goes back to a flare up of their old issues. Sometimes they come in with new or additional problems, and sometimes it's harder to deal with. I had a guy that had a long COVID, got a concussion, so like we stabilized him with his long COVID, then he got a concussion, then we stabilized the concussion, and then he got COVID again, and it just was like starting over.
Yeah, which is so frustrating for the patient. Hard. Yeah. But I think one of the things I always try to say when stuff like that happens is, if you got better once, you can get better again, right? Like we got you better, and we just have to start back, a couple steps backwards, but we're just going to keep going forwards again.
Yeah, and that's a lot of times what happens. You just find you probably scale the rehab back, to square one or maybe even square zero from where they were. And sometimes, this guy in particular, he had been going for like a couple years before he found me the first time, right? So it's like, hey, you're already here. We're like 2 years ahead of where we were when all this stuff started for you. So we're going to be fine. We've got you. And that's the thing, I think, with these autonomic nervous system people who have that affectation in their TBI, whether it's with these other contaminating aspects or not, you really do judiciously have to encourage them too, because maybe they've been through, some of those other tests, or they've been to a medical provider who kind of told them, your testing isn't really that bad, or whatever it is. I don't really, it's in your head kind of stuff, right? They've maybe been a little gaslit or something like that. So they're discouraged when they already come in, and it's like, I'm just going to see you because my wife dragged me in here, or, you're the last thing I could find on the internet. I've tried everything else, or whatever it is. And then, you start to see, hey, we found test XYZ. We've done some things. We've improved you, and listening. A lot of times they just want to be heard, right? So listen to them, talk about how your examination maybe fits some of the things they're saying. And sometimes you may see the exam get better and they still feel like crap. And well, that happens, that happens for sure. You just look at what you're missing.
And I think that with COVID, the other kind of unique thing was just the severe amount of damage to mitochondria that some people are experiencing, so that they are very, very fatigued. And it's, I use the phrase, of, sometimes you got to spend money to make money. And it's kind of the same thing where, our muscles are such a powerhouse for creating mitochondria. It's like, okay, I know you're tired, but you actually gotta, you gotta use it a little bit in order to create more mitochondria. Yeah. And so that process can be really a struggle for people, because like you said, every single day, the goalpost moves in terms of what somebody can handle. Yeah. I've been drinking Purity coffee now for over 2 years, and one of the things that I absolutely love about Purity coffee is the fact that they do rigorous testing for mold toxins, pesticides, and heavy metals, which allows me to be able to drink their coffee and rest easy knowing that I am not consuming toxic chemicals, mycotoxins, or possibly heavy metals. I know a lot of our listeners are paying a lot of attention to their health and trying to do everything they can to stay healthy. And if you are a coffee drinker, one of the things that I would recommend is making sure that you're drinking a coffee that isn't putting more toxins into your body. If you would like to try Purity coffee, you can get 20% off your first order using our promo code LIFEAFTER20 by going to puritycoffee.com and entering that in the promo code box at checkout.
Yeah, and maybe, they have a day where they feel pretty damn good, and then they try to do everything, that they've been missing out on for month, 2 months, year, or it's like, my wife has this list for me and I really wanted to get to it, and then they pay, the piper for it, so to speak, for a while. And that's part of the deal too. It's like, when can I get back to physical activity? All these kind of things after traumatic brain injury, or after, a long COVID affectation where they've been out of action for a little while. And that's the thing. I mean, it's like, most people just crave kind of feeling normal, right? It's like, I want to feel like I did before all this happened. And they start to get a little bit of a taste of that because the rehabilitation is working. And then yeah, they'll do too much. I've been guilty of that as well with orthopedic injuries or whatever else. It's like, how'd you break your back? Well, I tried to squat 600 pounds 4 weeks after knee surgery, stupid, right? You've been there.
Oh,
yeah. I got hit in the head. I'm fine. Let's roll,
Mm-hmm. Yep. I completely understand. It's funny. I think I suffered from feeling like I was invincible for far too long. And, I think that reality check was hard for me to recognize, like, no, you're not invincible. Maybe you shouldn't follow your friends as they huck themselves off that cliff on mountain bikes.
It looks fun. And, you get a little bit of that, that's the thing. Our brain loves dopamine. You want a little bit of that dopamine. It's a nice natural way to get a dopamine hit, and it's something you go, look what I mean, that's the thing. And like with you, it's like, what can't you do? You go, that's another thing I can do that a lot of people can't. And, we thrive on being able to do some of these things that we think, we can do better than a lot of other people as humans, whether it's hang drywall fast, or, have the best garden on the block or the best lawn on the block or squat 800 pounds or, whatever it is. And you go, hey, I just want to maximize my human experience as much as I can because we're only here for so long.
Well, I'm an Aries, so I have to try everything at least once.
Yes. Yes. What else can I do today? Yeah. Should read a book and go to bed. Nah.
Do you
read a book later?
So when it comes to, exercise, and obviously with both, the fatigue from long COVID and the autonomic dysfunction and the exercise intolerance that people experience after a concussion, do you help people to really dial in this kind of gradual graded exercise program? And how do you do that with people?
Yeah, I think, and again, the athlete, everybody, I like to say this, everybody's an athlete, right? But your athletics might be your garden or whatever it is. The thing, John Letty's work is really, really good for this. The old thought process was cocoon people. And then it's like, that's like the worst friggin' thing you can do is sit in the dark room and not expose yourself to the world. Like you said, you need to get back into the world and start to do some stuff, because if you don't use it, you lose it. So he did this work in 2013 on graded cardiovascular activity as a measure for, how recovered you are and as a measure for rehabilitating people. So, the thing, that the Buffalo treadmill test came out of this. A lot of people are starting to do those. I've got athletic trainers in town doing them now, which is great. It's like, oh, they failed their BTT. Can I send them over? Yeah, please send them over, because that's a measure of autonomic nervous system function as well. Again, you got a treadmill, or you don't even need a treadmill. You can walk and see what happens, right? So what's the symptom load somebody comes in with? Okay, XYZ, rate it, scale of 1 to 10. Okay, I want to start to do some things, and I can at least dilate my pupil a little bit now, John, right? Okay, we've got some sympathetic activation, so we can get blood to the brain and the body when you do some certain activity. I maybe will have them do a timed up and go test and see if I get pupillary dilation when they do that, because that'll tell me, okay, yeah, you can go for a walk now, that kind of thing. Real good. The timed up and go test, you have them walk 10 meters, see how fast they can do it. And again, you can measure some of these other neurological metrics associated with it that will do. And then, what's your symptom load? Rate it 1 to 10, get on the treadmill. When do your symptoms start to tick up? Okay, at X miles an hour at a heart rate of X. Okay, let's stop, see if it comes back down. Does it come back down? Cool. Okay, let's reduce the load by 20%. Do it again. Do the symptoms come back up, or are you good? You're good. That's where you're going to exercise until we assess you again and see things happen. If you do it again tomorrow and you get the headache at that 20% lower number, we lower it again by 20%. Whatever it is, whether it's the treadmill, or if they want to ride a bike, or if they want to play the trumpet, all these kind of things. I just had one of those this week. The high school guy, concussed, super jazz band, trumpet, wants to play. Well, okay, once we establish you've got an autonomic nervous system that's at least in the game, and the cool thing about this guy, like, he could do the Valsalva to play the trumpet fine. I'm like, thank God. He had a lot of things that I was glad were good. Like, he didn't have a big issue in his near point of convergence or accommodation. He had the ability to tolerate a Valsalva without getting a headache. I'm like, we're going to be fine. Those things you really, really like to see. But that's the thing. Take that, lower it by 20%. If you don't get symptoms, that's where you're exercising for the day. Whether it's gardening, doing farmer's carries, weightlifting, same thing. Lower the weight by 20%. If you don't get a headache, or you don't get clenching of the jaw, whatever you're bringing me, right? Whatever you're bringing me. If you don't get that, if you don't get cold.
It was really fascinating. One of the things that in hindsight, I recognized as kind of an autonomic symptom, because a lot of my concussions were mild in the sense that I walked away from them. I continued to do whatever I was doing. And then the symptoms were just kind of these like lingering things that I kept kind of like thinking were related to something else entirely. Well, one of the things that I figured out kind of in hindsight was that whenever I would go mountain biking, a lot of the trails that I would go on was always a steep uphill climb first before you got to the super fun screaming downhill. And what I found was that I would start out my ride, I'd be feeling totally fine. And then all of a sudden, my heart rate would get to a certain point, and it was like a switch got flipped, and all of a sudden my thoughts would turn so negative, and I would just be like, I hate mountain biking. Why am I doing this? I'm terrible at this. Why do I even bother? I don't want to be here. And I'm just like pedaling up this mountain, just angry. And in hindsight, I was like, that was my threshold before my autonomic nervous system just had some kind of limbic thing kick in, and the whole thing fell apart.
You go fully mesolimbic, and it's like, man, I don't really hate this. Do I want to do this anymore? And you go, man, if only I could have lowered the grade by 20%.
Exactly, but I couldn't make the mountain flatter, so.
Yeah, that's the problem. You go, no, I want that trail, damn it. That's my favorite trail. I don't want to go to that like crappy John McClaren trail.
Can't I just get a ride to the top so I can just go down?
Yeah. Put the ski lift in and, take your bike with you, right? But it makes sense. And that's the same thing, whether it is, the gardening or whatever it is that somebody really, really loves and they want to do. There's an autonomic nervous system component to being able to do anything where, even if you're playing video games, if that's all you want to do. I get a lot of kids that ask that, video games are killing me. Well, there's a lot of things going on, visual stimulus, a lot of eye movement, a lot of vestibular activation and things like that, which again, we've already talked about. You need fuel and oxygen for the processing. A lot of times it could be a primary autonomic nervous system dysfunction that's not allowing these people to be able to do that.
Well, and I think what you're highlighting is where functional neurology really excels, in that the way that you're looking at each of these patients is so completely individualized, whether you're talking about a professional weightlifter or somebody who just wants to garden or somebody who's playing video games or somebody who just needs to carry groceries up a flight of stairs. Functional neurology really excels in being able to take that one single individual person and say, what are you struggling with now? And how do we get you a little bit better so that you can do life better in whatever way that looks like for you? And I think that's what I really love about it is the flexibility, and then also the creativity in saying, if the goal is to get you to garden, then that might completely change what kind of therapies we're actually using or doing, as opposed to the power lifter.
Well, for sure. And sometimes that's the great thing about this stuff. That's one thing Professor Carrick, from the first time I ever saw him do a case, what if there's one thing I can do for you, what do you want it to be?
Right. What a great question.
Sometimes you might not get it, but at least I know where this person is, and then you meet people. And again, you've said this before on the podcast, you meet people where they are, you go to them where they are and you make it work. Maybe we go do your head-eye vestibular motion therapy in the garden or a garden, or I simulate a garden with a projector on my office wall or whatever it is, because, it's like I feel pretty good when I do your gaze stability exercises here or when I'm in my house where my walls are kind of plain, but then you get outside and it's like there's different visual context to the activity, right? Or whatever it is, visual, vestibular, maybe it's like they need to wear different shoes. There's something in that's causing the breakdown, and you can bring the rehabilitation to the place they want to be. The power lifter, you can bring the rehabilitation into the gym. I've got a Brock string and a saccade board and all this stuff right by my squat rack. So, I'm doing like, head tilts and all this kind of stuff between sets. And, it's like, well, does it help? I think so.
No, that's hilarious. I mean, sometimes in between sets when I'm at CrossFit, I'm like, I need to do some yes gaze stabilizers. Like, let's fire down this vestibulospinal pathway before I start doing my power cleans.
Yep. I wish I'd have brought my OPK strip in because I feel like I'm a little forward or, something like that, right?
Yeah. I mean, being able to understand how the system is wired and how to stimulate it so that you can create, the appropriate response is really the name of the game here. And like I said, I love the creativity that I see with all the different functional neurologists that I talk to in terms of what they're doing in their practice. And like you said, even like having someone do their therapies in the gym or in the garden or in the swimming pool, it makes a huge difference. Yeah. I mean, we're, like you said, it's all about context.
Yeah, that's the thing. What do you want to do? Let's make you better at it. Yeah. And let's make you better at it and not compromise yourself along the way. Ideally, it is the good thing, right? Yeah. We want to be well-rounded humans, and that's what we want to see in our exams all the time. But yeah, you know, really when it comes down to it, if you can get people to handle the activity that makes them the most happy, they're going to be a satisfied person. They're going to refer you more people than you probably wanted them to refer you, and all these kind of things. And it's just the way to organically build a practice. Just listen to people, give them the best version of yourself that you can, and do these kind of things. And they're going to be really happy. They're going to have a successful rehabilitation. And you know, the thing too, a lot of times people will ask me, how long do I have to do this stuff? You know, do I need to do this stuff forever? And I'm like, well, some of it you probably should. You know, I had that when I had my shoulder surgery last year. I had that epiphany where it's like, my therapist asked, you know, what do you do for your warm up before bench press? It's like 1 plate, 2 plate, 3 plate. And she just rolls her eyes at me, you know, and it's like, what, you know, that's just what I've done. You know, now it's like, I've got this 20-minute routine of old man warm ups before I lift that I'll do for the rest of my life because I want to stay healthy, you know, in my shoulders. And I do neuraxis work and things like that. Again, I wasn't doing that stuff before. And I'll tell people that, you know, it's like, you should probably, as long as you have a brain, do some of these things for the rest of your life. And the thing too, you know, that's to go back to, you know, the case where the guy had, you know, the COVID and the concussion and the COVID. If people continue to do some of these things, look at Joe Clark's research. It's preventative. You do these things and you have an event, you are way less susceptible than if you don't do these things and have an event, right? You know, if you're doing some eye movement training or some reaction time training or some aspect of balance training and you get hit in the head or you get your COVID or your influenza A or these kind of things, your nervous system is going to be hardened so that it minimizes the damage, right? That's the thing. It's like, you know, it's the same thing as lifting weights or doing CrossFit now. Like, we're doing this one because we want to, you know, we want to look and feel good now, but I want to be able to get off the toilet when I'm 80.
Right.
Everybody says it now. Why are you training? So I can get off the floor later.
Yeah.
Without help.
And I think too that just the very nature of what we're doing all day long in terms of the neuro rehab with our patients is like, when I'm having them doing saccades or pursuits, it's like I'm looking at their eyes. So I'm also getting a pursuit and a saccade in as I'm watching them do what I want them to do. And it's like, as I'm moving their arm in a figure 8, my arm's moving in a figure 8.
You're doing complex movements too. And it's unique. You know, you're getting a different activation with every person because they're stiff and heavy in different ways. Your cerebellum's like, yeah, you know, I want to come to work today.
Yeah. And so it's like, you know, if I've got someone looking at a Brock string and I'm pointing at the beads, well, I'm kind of doing the Brock string myself in that moment. And honestly, I feel like that is activating my brain all day long, literally just by working with my patients. It's like my brain is getting its own activity.
Absolutely. Yeah. And that's the thing. I mean, you look at, you talk to some of these people at like ISCN or, you know, what other things we get together, clinical jams or, you know, whatever it is, when you get a big group of people who've been doing some of this work a really long time together, you know, you get some of these people that are in their 6th, 7th decades of life. One, they're still working. 2, they're sharp as tacks.
So you mentioned you use a lot of the head-eye vestibular therapy as part of kind of creating better balance and integrity within the system. What other types of therapies or things are you incorporating in a lot of your rehab when it comes to people that have dysautonomia as part of their presentation?
Things I love. I really like to have people use fine motor activity. I just have found when you bring in some of those lateral cerebellar aspects, you know, coin rolling is one of the big ones. And you know, Carrick got me onto this, like everything, right? You know, and the thought process is, how do I activate the brain in a way that is judicious and doesn't bias that system too much one way or the other? Because what am I trying to do? As you said, I want to get the top-down stuff to talk to the vagus or talk to the IML to get it to do what it's supposed to do. Those neurons generally, when you have a TBI, themselves aren't damaged unless you've got a significant shear or an intracranial bleed or things like that. It's the connections, those white matter connections that get damage. You get the road construction, so to speak, is going on. And, now I've only got one lane when I should have three or so on when I'm driving. The fine motor activity is great because you don't get a super high level of activation in those brainstem centers like the nucleus tractus solitarius, where you can suppress an already suppressed sympathetic system by doing some of these big complex movements and things like that, which works in some cases really, really well. If I wanted to drive more of those parasympathetic aspects, I might do a little more complex movements because I get an activation of that NTS. I get some vagal activation to suppress the IML a little more. Increasing cerebellar output, really good for that, right? So, fine motor activity is really, really good. I get these, you can use like a poker chip or a 50-cent piece, like a quarter with some of these people is almost too small. I got these, I've got one, it says I was caught being good today. It's about the size of a 50-cent piece, and you just have people roll it, and it works super duper well. And I mean, people see me do it. It's like, well, I've been doing this every day for 3 years. Don't feel like you should do it. It's been part of my whole process of getting that brain to be better. So I'm pretty fluent with it. On a good day, I can do a dime. And that's another way you can scale the therapy, give them different weighted objects that are maybe that size, because again, the cerebellum likes that novelty, and it helps to drive into some of those autonomic activating centers, the locus ceruleus, so to speak. One of those areas that's very important to autonomic modulation. It's got like 313 different parts of the brain that pop into that little thing. And if it doesn't work really well, that's when you see these dysautonomia phenotypes. I may, again, if I can get some pupillary dilation on like a cognitive task, or I don't see them fail doing dual tasking on their balance, I might have them do some saccades. I like very small amplitude saccades. Generally, when I start these with dysautonomia patients who are a little less stable, I like to move away from center because it's easier to put the brakes on. You want people not to overshoot when they do saccades really early. It's harder to put the brakes on when you cross the nose than it is when you go away from the nose, that kind of thing. So we'll put them, maybe on a 45 where we combine the machinery for vertical and horizontal saccades, because again, it's a little nicer on brain activation. That's why you see all these Carrick brain exercises on the 45s. It's vertical and horizontal machinery working together. So it takes a little less, blood and oxygen to get that thing going. Then you'll see this all the time in people who have dysautonomia. You have them do saccades horizontally in the exam, and it's like, my God, I can't do that. And then they can do the verticals a little bit better, or vice versa. Usually, you vertical a little better than horizontal. And when you look at Professor Carrick's work that he did on, these 40,000 different groups stratified by age and all that, he found the vertical movements tend to be a little more accurate than the horizontal movements overall. Had you seen his latest paper?
And that was the one where he was really stratifying it by age range.
Age, age, sex, all this stuff.
Our kind of normative values really need to change based on not only age, but also gender.
Yeah.
That's huge.
Yeah. And you see, women do some things a lot better than men and vice versa. And concussed women perform better than regular men on a lot of things, and and not so well on others, but it's interesting. And when you look at this research that comes out, you start to tailor your exam expectations to that, and you can tailor your rehabilitation toward that. Where, if I'm dealing with a female patient with dysautonomia, I may do a little better with some saccades than I will with some pursuits. With a male, I might do a little better with some pursuits than some saccades, because they perform a little better in those tasks, even in a TBI, kind of context, even after more than one. So, we use some really small, subtle activations. Maybe you loop in some of those other things like the vagal nerve stimulation if I want to drive it a little bit, or things like that. I'll use the mini stim device or something that's like an SSEP on the tongue or on the trigeminal system. Those kind of things are really, really nice. Again, I want to see dilation on my pupillometry. Before I do a lot of that, I want to see, we'll do the hand grip test where, we're looking at, are we going with Ewing and Clark 16 on our diastolic, or do we want to see the full 20? The whole thing, when we do this hand grip test, we're getting a maximum hand grip. We're finding out that's kind of our baseline. We're going to 30% of that. We're sustaining that for 5 minutes. We're checking the blood pressure every minute. And Kurata and all these people found that diastolic number was the number that is the one that matters, the authoritative one for the autonomic nervous system. If I at 3 minutes, can't get my diastolic pressure to rise, depending on what source you read, between 16 and 20 millimeters of mercury, then I know I'm not activating my sympathetic nervous system super well. So you're going to be really, really judicious in how you drive your rehabilitation with these dysautonomia phenotypes, and then can I get it there? And then can I sustain it? You'll see this and you'll see it on the pupils all the time. Well, they got the T75, yay, but then it goes right back down into a full-blown constriction. And, I got to the 16 to 20 beats or millimeters of mercury, and then minutes 4 and 5, it goes right back down. Those are people, it's like you can introduce some of these things a little more than people that can't do it at all, but you still have to be really judicious and, just start small. Maybe, again, to kind of go back to a topic you guys have discussed really well, maybe we'll do some aspects of apophyseal glides in the cervical spine. We'll do some manipulation in the rib cage to maximize oxygen capacities and things like that, because that cervical spine has so much to do with how that autonomic nervous system activates.
And I think everything you're saying, one of the really important take home here is a lot of people, when they are booking kind of that initial appointment, they're like, why do you need so much time with me to do your initial assessment? Yeah. And this is why, because looking at the autonomic nervous system and even asking that question of, does this person even have enough sympathetic output to be able to handle the therapy? And if they don't, I need to back down on my therapy. And so it's like the reason we need that time with the patient up front to do all of our investigative work is because it matters, how they're performing on this pupil test really is actually indicative of what we are not or aren't going to do as far as their therapy or what we know that their system can or can't handle, at least as a starting point.
Yeah, and that's why I love that pupilometry app, because I can take that 4, 5, 6 times, really apply a therapy and see what happens, and it's not as fatiguing to people as some of the other things we might do are. It's hard to, and if you take a blood pressure 12 times during an exam, that can contaminate itself over time too, right? You'll see, a significant change just by doing it multiple times on the same arm in a time period that's relatively small. So it's not as good a data. The pupils, they're very quick to respond to therapy. I mean, again, when we're doing brain rehabilitation, you're seeing brain able to replicate proteins in a nanosecond. So you can really, really quickly add stability or detract from stability, really, really quickly, depending on the person and how they do. So yeah, it's like, why are you doing this again? Well, if I'm going to give you a saccade to the left, I want to make sure that it doesn't cause you a negative outcome. And because if I'm going to send you home with stuff, if I'm not doing, and we all practice a little differently too, but if I'm not seeing you in a 3 times a day intensive model for 5 days, maybe I'm sending some things home with you and I'm bringing you back in again in a few days or a week or something like that. Or I'm checking on you via telemedicine with my pupilometry if you've got that app. Or I've got some other things where, you've got somebody with you who can take blood pressures bilaterally and tell me what the response is after a few days of therapy where you can't get to me. I mean, they're coming from a few hours away maybe to see you, that kind of thing. I'm sure you're getting that a lot where it's like they're coming from, all over the state or even farther than that. They're going to maybe go home and take this stuff home. And I want to make sure that the outcome is as positive as possible. Do the least amount of negative that you can do and do as much positive as you can do with your rehabilitation. So, we'll loop some of those things in. I like looking at joint position errors in the cervical spine and using that as a rehabilitative model. There's so many ways you can do that. You can have people do, head laser things with eyes open. You can have them do it eyes closed. Those things are really, really good with these autonomic nervous system phenotypes where the neck's really involved. And again, using the neck gives you some more positive activation. Again, as long as we know it with diligence that it's good. Strengthening of the neck, that's one of those. I think you guys touched on that too. I think you're doing your best to correct the joint position errors is good before you get into a ton of heavy strengthening in the neck. You're going to get neck strengthening with general resistance training to some degree. But if you really want to specifically attack the neck, just make sure they aren't really, really skewed on their joint position errors. But you can do them together. You can do them in concert because a lot of times the strengthening helps with the joint position error processing as well, along with the manual modalities and so on.
Well, man, I think we covered a lot of information. Why don't you let people know
Yep.
kind of where they can find you, and now that you're back on social media?
Yeah. So back to Facebook. I've got a clinic profile. We're Advanced Chiropractic and Neurology PC. We're located, like you said, in suburban Omaha. We're located in La Vista, Nebraska. My website is www.omahaspinecare.com, curated by a friend of mine a long time ago. I was going to write it something different. He's like, no, make it something people understand, John. 402-597-2869 is our office number. You can feel free to reach out to me there or on Facebook. I've got a personal profile, the office profile, Instagram. I think I've got like 4 followers since I came back. So, you can look for me there if you want.
Okay. Well, and I'll put all of that in the show notes so that the links are there too.
Perfect.
Yeah.
Perfect.
Well,
Sounds great.
I appreciate your time, and thank you so much for coming on the show. Always a pleasure to talk to you. I love geeking out with you.
The pleasure's all mine. Thank you so much for the invite. I really, really am honored to be here.
Good. Well, we'll have to do it again.
Yeah, I'm in. For sure. Yeah, for sure. I'm in.